So, iatrogenic colonoscopic perforation is a serious complication which can happen during both diagnostic or therapeutic procedures. However, it is a rare thing to happen in expert hands, and the overall reported incidence of perforation is in the range of 0.02 to 0.8% for diagnostic procedures and 0.02 to 8% for therapeutic procedures. But if we consider the overall number of colonoscopies being performed across the globe, this number of iatrogenic colonoscopic perforations is not insignificant. And if we talk about the risk factors which increase the likelihood of a perforation from happening, the first and the foremost are colonoscopic therapeutic procedures. I'm going to talk more about these procedures in the next slide. Now, besides this, any patient presenting with colonic obstruction or active Crohn's disease or diverticulosis or with a history of previous abdominal surgery or comorbidities and is undergoing a colonoscopy also has a higher risk of perforation happening during the procedures. Last but not the least, the expertise of the endoscopist doing the colonoscopy is a very important factor for doing a safe procedure. Now, among the various therapeutic procedures such as colonic polypectomies, endoscopic submucosal dissection, or colonic stenting have a very high risk of perforation. Argon plasma coagulation, which is a wonderful modality for hemostasis in endoscopy, if not used properly, can lead to a bowel perforation. In the colon, the most common site for a perforation to happen during colonoscopy is the sigmoid colon, primarily because it's the narrowest part of the entire colon with an average diameter of around 2.5 centimeters. The next common site for colonoscopic perforations is the cecum, followed by ascending, transverse, and then the descending colon. Most of these perforations are usually intraperitoneal, although extraperitoneal ones can also happen. In fact, we can have a combined intra and extraperitoneal perforation, although extremely rare, but is still possible if the perforation is located between the intra and the extraperitoneal portion of the colon. Now, ASGE and ACG, Task Force on the Quality in Endoscopy, recommends that the maximum acceptable incidence of colonoscopic perforations should not be more than 0.1% for diagnostic procedures and should not exceed more than 1% for complex polypectomies and more than 7% for colonic stentings. Now let's understand the mechanism how a iatrogenic colonoscopic perforation happens. It can happen in any of these three ways, either due to direct trauma to the bowel wall, or due to barotrauma, or due to a thermal or a electrical injury to the bowel. Among these injuries, direct injury to the bowel wall is the most common cause of a iatrogenic colonoscopic perforation. This usually results in large perforations and can happen due to direct bowel injury because of wrong and rough insertion of the scope, excessive retroflexion of the scope, or excessive torsion of the scope. Bowel may also be injured indirectly due to excessive stretching of the colon due to looping of the scope. Now, in addition, if a patient has a long redundant colon or has multiple diverticula or adhesions, these further increase the chance of perforation to happen. Now, excessive distension of the colon due to overinsufflation can lead to linear lacerations in the colon, some of which can ultimately evolve into full thickness defects. Now, this type of perforation due to barotrauma is more often seen in the cecum, primarily due to its thin walled. Thermal or electrical injury of the colon wall can lead to ischemic injuries, which can result in a delayed perforation, and sometimes these delayed perforations may even be concealed by the surrounding tissue, presenting at a much later date as an abscess and thus further delaying the diagnosis. Now, coming on to some recommendations for the prevention of ICPs. First and foremost, learn the correct technique of doing the procedure. Now, during the colonoscopy, repeatedly shorten and straighten the scope, avoid looping as far as possible, and correct the loops properly whenever they are formed. And make sure that the endoscope progresses smoothly. Make sure of using the alternative procedures such as change of position of the patient, application of the external abdominal pressure, and underwater colonoscopy in difficult cases. And if you still face difficulty in advancing the scope, it is better to abort the procedure rather than risking a perforation. The second recommendation is to use insufflation judiciously. This is done to avoid barotrauma to the bowel. So please remember the dictum that you must use as much air as necessary and as little as possible. Now this helps to keep the colon short, supple and pliable. In long procedures like a ESD, it is better to use carbon dioxide as it is more rapidly absorbed as compared to air and thus minimizes bowel distension and the risk of perforations. The third recommendation is for polypectomies. Now give a good submucosal injection of saline and have a good mucosal lift, especially when excising a subpedunculated or a sessile polyp, as this reduces the risk of electrical damage to the underlying muscle layer. Always use a blend mode of current preferably, and do a cold polypectomy for a thin stalked small polyps. And remember that while doing an en bloc resection for larger lesions, do not catch more than 2 centimeters of the tissue in the snare in one go. Again, while doing an ESD, have a good mucosal lift by injecting submucosally. And remember, if there is no mucosal lift seen, then this patient has invasion of deeper layers and is not a candidate for doing a ESD. Next recommendation is that while doing a colonic stenting, first of all, choose your stents wisely. And if you need to dilate before deploying the stent, then do it carefully and do not dilate more than required. If at all the patient is on bevacizumab therapy, avoid putting in the stents because this is associated with extremely high risk of bowel perforations. The next recommendation is concerning stricture dilatations. While doing CRE balloon dilatations, always remember the rule of 3, which tells you that in one sitting, do not go beyond 3 subsequent diameters of the dilator. And in patients who are having active Crohn's disease, it is better to avoid pneumatic balloon dilatation. And if at all you have to do it, then do it carefully, especially in patients who are suspected to have the presence of either a fistula or a long stricture. This last recommendation is actually meant for the trainers. Please remember that perforations may happen during training the fellows. So we need to keep an eye on the trainee, especially if they are finding it difficult to negotiate the colon or if diverticuli or obstruction is present. We need to keep a low threshold at which point the trainer should take the charge of the procedure and decide to either abort or complete the procedure.